Hi, I'm Dr. Dayanand. I teach pathology in Bangalore Medical College. I thank RGHS for coming up with this platform. Hope this will help most of the PG aspirants. It is very difficult to teach somebody how to approach to MCQs. I thought, let me take one particular topic and start solving the MCQs that might be of definitely help to you. Today, I'll be talking on cell death in health and disease. This is a normal cell. This has got the capacity to work within very narrow range. Whenever there is an alteration in the external environment, it has got the capacity to manage without showing any alteration either in its structure or in its function. This capacity of the cell is what we mean by cellular homeostasis. But if the altered environment persists for a longer time, the cell starts getting adapted to this altered environment. If it does so by increasing its number of organelles and thus its size, we call it as hypertrophy. If the external environment is adverse, then still starts surviving this altered environment by reducing the number of organelles and thus decreasing in its size. And this is what we mean by atrophy. If the altered environment is beyond its control, it starts showing the evidence of cell injury. To an extent, whatever the injurious changes we see can still be reversible. Let us take an example of hypoxia. Whenever there is an hypoxia, there will be reduced availability of the oxygen. Whenever the oxygen availability is less, oxidative phosphorylation starts failing and the amount of ATP produced will start falling. Remember, most of the events in cellular metabolism is energy based. The first things probably to get affected is sodium potassium pump. When the sodium potassium pump start failing, there will be influx of sodium and this carries along the water and thus results in the cellular edema. Remember, the cell membrane is bound to the underlying cytoplasm through the cytoskeletal proteins and that is also energy bound. When the ATP is less, it starts giving away and there will be formation of cellular blebs. Attachment of ribosomes to the underlying endoplasmic reticulum is also energy bound. When the ATP starts falling, these ribosomes starts getting released, polysome starts getting released and there will be defective protein synthesis. Remember, at this point of time, the cell wants to produce energy at any point of time and takes up glycolytic pathway. The products of this glycolytic pathway is the pyruvic acid and the lactic acid, and this brings down the pH of the cell. When the pH of the cell starts falling down, this creates an acidic environment, in turn causing irregular clumping of chromatin. So all these are the features of reversible cell injury. One is the cellular edema, cellular blebs, swollen organelles like endoplasmic reticulum or the mitochondria, or you can see the detached ribosomes and irregular clumping of the chromatin are the features of reversible cell injury. Still, if the injurious stimuli continues for further, it starts showing irreversible damage, and that's what we mean by cell death. Cell death can be of many types. One of the type is necrosis. It is very difficult to say at what point of time the reversible cell injury gets transformed into irreversible cell injury. But what morphological evidence it brings out can be evident under the ultrastructural changes can be evident. Say, for example, the rupture of the sarcolemmal membrane or the amorphous opacities inside the mitochondria will give us clue that probably the cell has gone into the irreversible damage and cell death. And this dead cell slowly brings in morphological changes, and that's what we mean by necrosis. Ultimately, a necrosis is a morphological change that follows the typical form of cell death. At the same time, there is one more form of cell death called apoptosis. Remember, in apoptosis, there will be activation of intrinsic molecular pathway, which in turn activates cellular proteolytic enzymes, which in turn fragments the cellular genomic DNA and both nuclear and the cytoplasmic protein, resulting in multiple apoptotic bodies. These are the two principal pathways of cell death. So, a normal cell which has start showing the reversible change, and when it fails to control it, if the injurious stimulus still further, there will be a damage to the cytoplasmic membrane and permanent damage to the mitochondria, and that results in cell death, and that's what we mean by necrosis. So, necrosis usually gives clues behind, because it shows the ultrastructural changes in the form of ruptured cell membrane, in the form of amorphous opacities inside the mitochondria. It do show the biochemical changes, in the sense, whenever there is a rupture of the cytoplasmic membrane, there will be release of cytoplasmic proteins. So, elevation of the cytoplasmic proteins do give us the clue, probably the cell must have undergone the necrotic change. Do show morphological evidence. Yes, once the cell dies because of necrosis, after some point of time, it starts showing increased cytoplasmic eosinophilia. It can showing evidence of pycnosis, karyorrhexis, and karyolysis. And thus, it gives us a clue that the cell has died by the process of necrosis. Remember, necrosis can always be pathological. It cannot be physiological. There should always be an external injury which must have killed the cell. It always elicits the inflammatory response. Remember, whenever the cell dies, there will be release of damage-associated molecular proteins called DAM. When the DAM protein gets released into the external environment, it starts attracting the inflammatory cells, and thus a cell which has undergone necrosis will invariably elicit inflammatory response. And always and most of the time, it is an external injury which is the reason for necrosis. So, at the same time, let us see how apoptosis results. Whenever there is an apoptosis, say for example, apoptosis can be physiological. It can be during the process of embryogenesis, supernumerary cell with an extent of surgical precision gets knocked off by initiating the suicidal program inside the cell. This results because of activation of intrinsic molecular pathway, which in turn activates the several proteases, which in turn breaks down genomic DNA and both nuclear and the cytoplasmic proteins, resulting in formation of multiple apoptotic bodies. Cellular enlargement may be a feature in necrosis, but here there will be condensation of the cytoplasm. There will be condensation of the organelles and resulting in the formation of numerous apoptotic bodies. During this point of time, the phosphatidylserine, which is supposed to be located inside the cell membrane, gets flipped out, start getting expressed on the outer surface. And this sends us a message saying that eat me signals. And once this eat me signals gets released, that gets recognized by the surrounding phagocytes, and these phagocytes engulf these apoptotic bodies. This process is called efferocytosis, and thus most of the apoptotic bodies gets cleared away by the macrophages, leaving behind no clues. So many a times, even after the apoptosis, we won't have any clue at all. So apoptosis doesn't leave back clue many a times. At times, it can show the ultrastructural changes in the sense, much earlier, if you are able to visualize under the electron microscopy, you will be able to see the ultrastructural changes like the karyorrhexis, means the pycnotic nuclei showing fragmentation and getting attached to the cytoplasmic membrane, inside the cytoplasmic membrane. It does not show biochemical change. Remember, the crucial difference between the necrosis and the apoptosis is, in apoptosis, the cell membrane is always intact. When the cell membrane is always intact, it never releases the biochemical and never releases the protein, cytoplasmic protein, and thus it does not give any biochemical change. And at times it can show morphological changes in the sense, if the apoptosis is extensive, we might start recognizing numerous apoptotic bodies that is being present there and never elicits inflammation. Remember,
Rupture of the cell membrane, release of damp is the reason for the inflammation. Here in apoptosis, there is no chance of rupture of the cell membrane, and thus apoptosis will never elicit the inflammation. It can be physiological and can be pathological. Necrosis is always pathological. Remember, the apoptosis can still be physiological. During the embryogenesis, it knocks off the supernumerary cells. During the process, during the process of development, self-reacting lymphocytes gets knocked off, and several other features, in several other physiological process, it do play a role. At the same time, it can be pathological. It can recognize the tumor cells, knock it off, and the cell which is damaged by chemical, what's that, chemotactic agents or the radiation gets knocked off, or if the cell is undergoing the endoplasmic reticulum stress, can get knocked off, or it can, a cell which is infected by the virus can get knocked off by the process of apoptosis. So invariably, most of the time, it is the internal damage which can result in the process of apoptosis. And invariably, there will be role of the molecular pathway, the transduction pathway, which in turn inducing the activation of proteolytic enzyme is the reason for apoptosis. Okay, so let us see the few examples. This is the coronary showing up atherosclerotic block and thus bringing in the narrowing of the vessel. What you're seeing is the normal myocardium. This is the total myocardium, which is showing the necrotic area. And this is ischemic damage to the myocardium will always bring coagulative necrosis. You recognize the coagulative necrosis by the shadowy cells, where the cellular morphology, the cellular borders are retained. Cytoplasm starts appearing more eosinophilic. There might be loss of nuclear protein, and you get to see the contracture band necrosis. And these are all the features of ischemic necrosis that has resulted in the coagulative necrosis. Liquefactive necrosis. All pyogenic bacterial infection can bring in liquefactive necrosis. At times, ischemic damage to the brain can result in the liquefactive necrosis. Remember, ischemic damage to all solid organ will result in coagulative necrosis, but for brain, where it results in liquefactive necrosis. So this is the lung where you are seeing an evidence of abscess. Under the microscope, you are seeing the sheets of neutrophils with a bacterial colony, and this is an example of liquefactive necrosis where the neutrophils have started coming there, started releasing their enzyme, and it elicited the process of electrolysis and thus brought in the liquefactive change. And this is a case of lung showing caseous necrosis. A caseous necrosis is where you get to see the combination of both the coagulative and the liquefactive necrosis. Coagulative necrosis is solid in nature. Liquefactive necrosis is illiquid in nature. The combination of both becomes semi-solid, and that's what you look like. That's what you appreciate in caseous. It look like semi-solid, cheese-like, the reason what the caseous. And the caseous necrosis is a feature of tuberculosis. And this is a structure of mesenteric pad of fat, which is showing the gray-white, the pearly-white chalky area, suggesting the evidence of the fat necrosis. Under the microscopy, hyaline degeneration, neutrophilic infiltrate, calcification, and giant cell formation can be a feature of fat necrosis. The last form of necrosis is fibrinoid necrosis. Usually, you get to see an antigen-antibody complex mediated damage. Remember, whenever there is an antigen-antibody complex goes and gets stuck on the endothelial cells, the macrophages try to eat that by the process of phagocytosis, but it fails to do so because it cannot close the pseudopores across. In this process, the neutrophils gets frustrated, sticks its pseudopores on the endothelial cells, and puts away the spits of the enzymes on the surface of the endothelial cells, and thus brings in damage to the vessel, which has resulted in the leakage of fibrin, and that is in turn leads to fibrinoid necrosis. This is an example of gangrenous necrosis, where there is an ischemic necrosis with superadded putrefaction, where you can get to see the anaerobic bacteria colonizing on in an ischemic background. So let us go to the few points about apoptosis. Invariably, whenever during the process of embryogenesis, it starts with a mass of cells. with an head mass or the limb birds. But later, with the precision, this goes ahead to form Deepika Padukone. Remember, this is because at the crucial point of time, with the surgical precision, the supernumerary cells gets knocked off, resulting in the formation of beautiful Deepika Padukone. That precise is the nature. Between the 100, between the 1,000 cells, it targets the cells which needs to be targeted, it needs to be knocked off. That is the capacity of the apoptosis. Okay, look at this. How a limb bird has been transformed into beautiful fingers and palm creases. That's all because of the process of apoptosis, which is a physiological process. So normally, when a cell gets exposed to a growth factor or the survival signals, that in turn stimulate the activation of pro-apoptotic proteins. The pro-apoptotic proteins like BCL2, BCLXL, MCL1. These are the pro-apoptotic proteins. What do? They go and stabilizes the membrane of the mitochondria. This stabilization of the membrane of the mitochondria is necessary for the normal survival. Look at this example. Whenever there is a loss of survival signals, or whenever there is a DNA damage, either when it gets exposed to radiation or the chemotactic chemotherapy, as a part of chemotherapy, if there is a damage to the DNA, the cytoplasmic sensor sends that. The cytoplasmic sensor, like BH3 only protein, BIM, PAD, PUMA, NEXA, they are the cytoplasmic sensors of apoptosis. What do? They in turn destabilizes the anti-apoptotic proteins like BCL2 and results in the polymerization of pro-apoptotic proteins like BAX and BAC. What does this BAX and BAC do? It creates a hole. It opens up the mitochondrial transition membrane pore, and that increases the permeability of mitochondrial membrane. What will happen now? The cytochrome C starts getting released into the cytoplasm, and this cytochrome C in turn gets attached to the apoptotic activating factor, which in turn activates the caspase 9. Caspase 9 in turn activates caspase 3 and the caspase 6, which in turn inhibitors of DNAs and activates several proteases, which results in the breakdown of genomic DNA, and both the nuclear and the cytoplasmic protein are resulting in the formation of several apoptotic bodies. This is what I explained now is an intrinsic pathway or the mitochondrial pathway of the apoptosis. At the same time, you do have got the extrinsic pathway. Say, for example, in autoimmune diseases like SLE or a virally infected cell, it starts expressing death receptors on its surface. When the fast receptors, if it gets expressed on its surface, it gets recognized by the fast ligand, which is bound to cytotoxic T lymphocytes. When it gets bound to each other, there will be there will be polymerization or the multimerization of these death receptors, which in turn activate the fast associated death domains, which in turn binds to pro-caspase 8 and gets in turn activates the caspase 8. Remember, this caspase 8 in turn activates caspase 3 and the 6, which is the process, which is an execution pathway, which in turn inhibits the inhibitors of the DNAs and thus results in the fragmentation of the DNA and causing the formation of apoptotic bodies. So sometimes, remember, say in the viral infection, virus is tremendous. It knows once it gets infected, it might get knocked off by the process of apoptosis. At that point of time, it can produce certain proteins called flip proteins. What does this flip protein do? The flip protein goes ahead and can inhibit the caspase 8 and can thus prevent the process of apoptosis. To overcome this, the cell can take up another pathway where there will be activation of receptor integrated phosphokinase protein. Receptor integrated phosphokinase protein in turn can get attached to the MLK1 protein, and MLK1 protein can make hole on the cell membrane and kill that cell. So now what is this? Here, there is an activation of molecular pathway. At the same time, there is a rupture of cell membrane. Rupture of cell membrane is a feature of necrosis. Activation of molecular pathway is a feature of apoptosis. Where there is a combination of both, we call the process as necroptosis. This is what we get to see in several viral infections like CMV, on steatohepatitis and pancreatitis. We can get to see the cell death occurring because of the process of necroptosis. There are several other rare forms of cell death like ferroptosis, where it can utilize the intracytoplasmic iron and thus increases the production of free radicals. Both free radicals and the iron can overutilize the glutathione oxidase system and thus can make the cell more prone for peroxidation and can kill the cell. And that's what we mean by ferroptosis. That's also a part of cell death. Pyroptosis. Pyroptosis, and many of these bacteria, a bacteria can straight away can cause the damage to the cell membrane, can kill the cell. This is the process of necrosis. At the same time, bacteria can activate the cytoplasmic sensor, and that is what we mean by inflammasome. Remember, this inflammasome can activate the caspase 1, and caspase 1 breaks the pro-interleukin 1 protein and liberates lots of interleukin 1. And interleukin 1 is the reason for the formation of fever and the chemo attraction of neutrophils. And this is the process of pyroptosis, where the bacteria not only utilizes the necrosis, liquefactor necrosis, can also utilize the pathway called the pyroptosis, where it can utilize the caspase 1 and can produce the interleukin 1 in excess and can cause the process of cell death. So these are the different forms of cell death. So this is the brief introduction about the cell death what I have given. Let us see how can we start solving some MCQs. True about caspases caspase is a proteolytic enzyme which plays vital role in apoptosis. We have just now heard caspase 8, caspase 9, caspase 1 and all that. So it plays vital role in the process of apoptosis. Remember, it's called caspases because it do have got cysteine residue and start lysing after the aspartic acid unit. So the reason why it is called caspases. So first option is it initiates necrosis. No, caspases never has any role in necrosis. We have understood that now. It initiates necroptosis. No, necroptosis, just now we discussed, there is an overlapping feature of necrosis and apoptosis. It's also known as caspase independent pathway of cell death. So there is no activation of caspase. Instead, it is receptor integrated protein kinase which gets activated, which in turn can activate the MPLK1 protein, which can cause the lysis of the cell membrane. They inhibit proteases. No, they are supposed to activate the proteases, which is responsible for the fragmentation or the breakdown of both nuclear and the cytoplasmic protein. They cleave inhibitors of the DNAs. I went on telling you the major function of the caspase is to inhibit inhibitors of DNA's protein. That is when the DNA, genomic DNA, gets fragmented and thus initiate the process of apoptosis. Ischemic damage to heart results in, I already told you, ischemic damage to any solid organ results in coagulative necrosis. But for brain, only the brain you get to see the liquefactive necrosis for unknown reason. Liquefactive necrosis you get to see in bacterial infection, fibrinoid necrosis in antigen antibody mediated cell damage, and as we know, the caseous necrosis is a classical feature, pathognomonic feature seen in cases of tuberculosis. So the answer is coagulative necrosis. It's quite easy. Most pathognomonic sign of irreversible cell injuries. I told you swelling of the cell membrane, second option, can be a feature of reversible cell injury. Ribosomes attached to the endoplasmic reticulum. I told you the ribosomes needs energy to get bound to the underlying endoplasmic reticulum. Whenever there is a reduction in the ATP, ribosomes gets released. When the ribosomes gets released, there will be defective protein synthesis. There will be failure of protein synthesis. Clumping of nuclear membrane, clumping of nuclear chromatin rather, is a feature of reversible cell injury rather than the irreversible cell injury. whereas the amorphous density in the mitochondria, amorphous opacities in the mitochondria is an ultrastructural feature which suggests cell is dead. So, the most pathognomonic sign of irreversible cell injury is amorphous densities in mitochondria. What's true about apoptosis? All are except, remember, whenever you are reading the MCQs, read the stem carefully. Usually, whenever we are preparing the MCQs, we need to highlight if it is a negative question. Say, for example, it's a negative question where the except has got been highlighted. You need to be very careful whether when you're reading the stem or the distractor, look for the negativity being present there. True about apoptosis are all except inflammation is present. Remember, we all know in apoptosis, there won't be damage to the cell membrane, there won't be release of DAM, so there can be no question of inflammation. So the answer will be first A, inflammation is never present in apoptosis. Chromosome breakage, yes, it can be seen in apoptosis. Clumping of chromatin is a feature of apoptosis. Cellular shrinkage is a classical feature of apoptosis. B, C, D option is a classical features of apoptosis. What is not seen in apoptosis is the presence of inflammation. The marker of apoptosis is caspase 1, option 4. No, remember, caspase 1 plays role in pyroptosis. The question is apoptosis, not caspase 1. ATG16L1, that is the protein which is responsible for the autophagy. It is a marker for autophagy, not for the apoptosis. PE, phosphatidyl ethanol lipidase LC3 protein is the one which initiates the process of autophagy, and thus both the option B and C are the markers for autophagy, not for apoptosis. So whatever left is annexin B. Remember, annexin 5 goes and gets bound to the phosphatidyl serine when it starts getting expressed on outer side. Remember, I did say in apoptotic bodies, the phosphatidyl serine, which is supposed to get expressed inside the cell membrane, starts getting expressed outside. That is when it starts sending a signal, eat me signals to the surrounding macrophages. And that is when surrounding macrophages recognizes them, eats away, and disposes what we call is efferocytosis. Annexin 5, which is a cytoplasmic protein, has got a tendency to get bound to the phosphatidyl serine when it gets expressed on the outer surface. All are reversible injury of cell except irregular chromatin clumping, karyorrhexis, fat cell accumulation, and cell wall swelling. Cell wall swelling is a feature of cellular edema. It can be seen in reversible injury. Fat accumulation can be a feature of degeneration that can be seen in reversible injury. Irregular chromatin clumping is a feature of reversible injury. That's because of reduced pH or the acidic environment. If the nucleus, the chromatin starts getting fragmented, that is when is a feature of irreversible cell damage. Examples of hyperplasia include cardiac enlargement seen in hypertension. Cardiac muscle, myocyte, is a permanent organ. It doesn't have the capacity to proliferate. When the cell cannot proliferate, then there cannot be a question of hyperplasia. So, cardiac enlargement seen in hypertrophy can always be an example of hypertrophy rather than hyperplasia. Enlarged liver in steatosis. Remember, accumulation of fat in liver, hepatocyte, as a part of any damage is a feature of degeneration. It can never be hypertrophy. It can never be hyperplasia. Skeletal muscle enlargement among the weightlifter. Again, the skeletal muscle is a permanent tissue. A permanent tissue cannot regenerate, cannot proliferate. So, that can only be hypertrophy that can occur rather than the hyperplasia. The only example, only the correct answer is the glandular epithelium of pubertal breast. In the sense, during the puberty, the size of the breast increases. That is because of increased number of glandular epithelium, where there is a true hyperplasia occur. 8. You are asked to participate in a research project on myocardial infarction in a rat model. Which of the following occurs in ischemic cell injury? Efflux of potassium and sodium, influx of potassium and calcium, efflux of potassium and water, influx of sodium and water. I told you in reversible injury, the initial phase, the reduced ATP results in the failure of sodium potassium pump. When the sodium potassium pump fails, there is an influx of sodium. When there is an influx of sodium, it brings along the water inside, and that is the reason for cellular swelling. And the right answer is influx of sodium and the water here. Regarding the adjacent picture, which statement is incorrect? It's a negative question. Incorrect. What you are seeing in the picture is the portal triad and the hepatocytes, and the most of the hepatocytes as shown appears empty. And that is because there is an accumulation of fat globules which have pushed the nucleus to the periphery. This clearing can still be because of water, hydrophic degeneration, but the pushing of nucleus to the periphery would not have been there. It can still be a feature of glycogen storage disease, but still the glycogen storage disease, you would not have seen the nucleus being pushed to the periphery. So most possibility here, it's a fatty degeneration, what you're seeing in the liver. It may result because of protein malnutrition. Protein malnutrition, yes. The limiting step in the lipid metabolism is the formation of apoprotein. And for the formation of apoprotein, you need to synthesize the apoprotein. And whenever in the protein malnutrition, the amino acid pool is empty. So there won't be synthesis of apoprotein, and there won't be fusion of apoprotein with the triglyceride, and thus there won't be formation of lipoprotein, which in turn results in the accumulation of triglyceride. Yes, it is right. It may result from the anoxia. We all told you the hypoxia. And hypoxia can cause the detachment of ribosomes from the underlying endoplasmic reticulum. When the ribosomes get detached, there will be defective synthesis of the protein. When the protein doesn't get synthesized, there won't be a formation of apoprotein. When there is no formation of apoprotein, lipoprotein won't be formed, and there will be interference in the lipid metabolism, resulting in the accumulation of triglycerides in the hepatocyte, and that's what we mean by fatty degeneration. It may result from that. Yes, it can result from the diabetes mellitus, because what is diabetes mellitus? There is reduced insulin. What is the role of insulin in lipid metabolism? It inhibits lipolysis. What will happen if there is a reduced insulin? There will be increased lipolysis. What do you understand by increased lipolysis? More and more fatty acids are entering, but the fat cannot convert all of them. They may convert all of them into the triglyceride, but there may not be sufficient apoprotein to form the lipoprotein. Thus, increased formation of triglycerides can bring in fatty chain. It may result from the cholestasis. So, cholestasis is an accumulation of bile pigment inside the thing, the accumulation of bile inside the hepatocyte. So, the last answer is incorrect regarding the fatty liver. What you're seeing in this picture is the numerous Samoma bodies. Samoma bodies is the laminated deposition of the calcium. It's formed only in coagulative necrosis. No, it can be formed any necrosis. It can be formed in coagulative necrosis. It can be formed seen in gaseous necrosis, or it can even be formed in the fat necrosis. So it can seen in any necrosis. Only in coagulative necrosis is not right. It does not occur in heart valve. The calcification, dystrophic calcification, can be a part of calcified aortic valve. So it can occur even in the aortic valve. It never causes the dysfunction. We cannot say it never. Usually it doesn't cause the functional dysfunction. We have seen the condition called alveolar lithosis, where the multiple dystrophic calcification can be seen in the alveolar wall, alveolar space, and thus can compromise the respiration. Or extensive calcification in the liver can result in the altered liver function, can bring in functional dysfunction rarely. It does occur in papillary carcinoma. Yes, it can occur in papillary carcinoma. Most of the papillary carcinoma has got high proliferative index, and thus the chances of individual cell necrosis and thus formation of calcification is known there. So metastatic calcification occurs in damaged heart valve, old lymph nodes, or atherosclerosis. All these cases, there can be metastatic, there can be dystrophic calcification rather than the metastatic calcification. Metastatic calcification usually results in gastric mucosa, lung, blood vessels, and the kidney. Remember, all these organs plays vital role in this excretion of acid. Whenever it is trying to excrete, push off the acid, it creates an alkaline environment inside, and that is the reason why there will be calcification happening inside in the gastric mucosa, kidney, vessel, inside the vessel, and the lung. Regarding atrophy, all are correct except decreased microfilament. Yes, there will be decrease in the microfilament. Decrease of endoplasmic reticulum. Yes. Decrease in the autophagic factors. No, there should be increase in the autophagic factors. Decrease in the smooth muscle endoplasmic reticulum. There can be, yes. Decrease in the smooth and rough and the microfilaments can be a feature of atrophy, but there would have been increased autophagic factor because the autophagy is the reason for atrophy. During the autopsy, it was found out that the lungs of form have brown color. It's known that the patient has suffered from the venous congestion in the pulmonary circulation. What process did cause a change? Whenever there is a retrograde pressure because of left heart failure, there will be pulmonary congestion, venous congestion. Whenever there is a pulmonary venous congestion, there will be extravasation of RBCs inside the interstitium and the alveolar space, and it thus results in the formation of hemocytic pigment. And remember, hemocydrosis is the reason for the brown interstitial blood. Calcinosis, jaundice, melanosis, porphyria cannot explain as a part of venous congestion occurring there. Patient admitted with the substernal chest pain, 4 hours duration. Lab test revealed increased level of serum troponin I. This is most likely due to irreversible damage to mitochondria, nuclear lysis, damage to the plasma membrane, and release of DAM. I told you the release of DAM is the reason for the causation of inflammation. Damage to the cytoplasmic protein is the reason which starts releasing the cytoplasmic protein. That is how the serum troponin I, which is one of the cytoplasmic contractile proteins seen in the myocardium, whenever the myocardium undergoes ischemic death, there will be rupture of the sarcolemmal membrane and release of serum troponin, and thus we start getting the biochemical evidence of raised troponin I. Nuclear lysis and the irreversible damage to the mitochondria may not explain the raised troponin I. As we already discussed before, the laparoscopic examination of the abdomen was performed in a 50-year-old chronic alcoholic man. Surgeon noted the digestion of the tissue with soap formation and calcification. Which of the following is the most likely characteristic? It is a classical example of enzymatic fat necrosis, where there is a result as a part of pancreatitis, where the lipases enzymes get regurgitated or can be released and can cause damage to the can cause enzymatic necrosis to the lipids, which can result in fatty acids, which can undergo saponification and calcification. And calcification in the naked eye start looking like a chalky white precipitates in the background of adipose tissue. It's a classical example of enzymatic fat necrosis. So, whenever we are approaching to the MCQs, read neatly the stem, understand, read once again the different distractor, and start applying the basic concept what you have learned. So stick to the basic concept and it will help you in solving those. Thank you very much for giving